All right.
All right. Welcome, welcome. Good evening. Season's greetings, everyone. So excited to see you all joining us here. Welcome to Epicure's December clinical webinar, co-hosted with Dr. Shar Institute. Give everyone a minute here to come in, get settled. I don't know where you're all calling in from. Usually we've got this global contingency anymore, which is amazing. It's cold here in Brooklyn, so I've got my peppermint tea. Take a moment, pour yourself a glass of tea, maybe a glass of wine. I don't know, no judgment. It's the holidays. So hopefully you guys are taking some time to indulge, including for a wonderful evening of content this evening with Dr. Ann Lee, who really needs no introduction. She's been a presenter with us before, one of our, I think, around 20 webinars that we have recorded with incredible content and topics. And this is a wonderful topic by a wonderful presenter to add to the list tonight. Is it non-celiac gluten sensitivity or is it IBS? Work with many of you and hear this question come up a lot. So we'll be really fascinated to hear from the wonderful Dr. Lee on this topic. For those of you I don't know, I'm Jamie Hawk with Epicure, and I'm our VP of Network Development and Strategy. I'm a foodie and passionate believer of nutrition to heal people and improve patient outcomes, as are all of you. So just a quick overview of what you can expect tonight and who Epicure is in case you're new to us. First of all, you will all be off video and on mute for the duration of tonight's webinar, but we certainly will be excited to answer your questions at the end of our presentation. You can submit those questions at any time through the Q&A function at the bottom of your Zoom panel. And then Megan will help moderate, who I'll introduce in a second, that Q&A at the end of tonight's presentation. It will all be recorded. You will have access to the recording via email. You'll receive that access via email in the coming days. And that will also include your CPE certificate. So please look out for an email from us. Quick overview of Epicure before we jump into the awesome content this evening. We work with incredible clinicians all over the world who use nutrition to impact and improve healthcare outcomes. Nutrition is a vital part of the health plan. Registered dietitians are extremely important for people to see, especially those living with GI conditions. Anne and Megan Donnelly, who you'll meet in a moment if you don't know her already, are wonderful examples of those experts who believe in evidence-based care, which necessarily leverages nutrition. And here's just some examples from the 1,000 clinicians who refer to us across the country. And we're very proud of the community that we've developed who leverage our food. So our first menu is all low FODMAP, which we have lots of educational resources to hear about, and Anne may share about some of that this evening. But it's really medically tailored for people with IBS and Crohn's, colitis, and SIBO. And then it's also all 100% gluten-free for those who are celiac or have non-celiac gluten sensitivity. It can be complicated, and we know that adherence can be really low to eat low FODMAP, but it is evidence-based and has been shown to improve symptoms in up to 86% of people with IBS, for example. We love being a support tool for all of you as clinicians in your practices. As I just mentioned, low FODMAP can have very low adherence rates, and sometimes it can be difficult to explain, or people are not a good candidate to eat low FODMAP because of disordered eating or other factors that may impact their ability to access low FODMAP food. So sometimes trying Epicure in just a few days will elucidate whether or not low FODMAP would actually work for that patient. So we love to provide diagnostic support. All of our meals are prepared and ready to eat, so it takes out the stress. It gives people peace of mind to have these prepared foods arrive at the doorstep they know will make them feel good each week. And we believe in everyone eating as expansive a plate as possible. So we have a wonderfully varied menu to ensure that their nutritional adequacy, the minerals and vitamins and macronutrients that they're getting are up to snuff, which can also be difficult with low FODMAP. and really why I get excited to come to work every day. Even though work now is in my home, it still excites me to hear these testimonials from people who do hear about Epicure from their doctors. It really strengthens their relationships with their doctors and dietitians, and we're honored to be here bringing this expert content to you with the wonderful Megan Donnelly, our co-host from Dr. Shar Institute. Megan is a registered dietitian living in New York City, my neighbor, where she works as a nutrition services manager at Dr. Shar USA. She joined the Dr. Shar team in 2018 after completing her dietetic internship at the James J. Peters VA Medical Center in the Bronx. Megan, as I can attest to, having worked with her, feels passionately about improving quality of life for people following restrictive diets through culinary education and through practical application of nutrition science. Her specialties include celiac disease, irritable bowel syndrome, and chronic kidney disease. Megan has a master's degree in nutrition and dietetics from New York University and a bachelor's degree in biology from the College of the Holy Cross. Without further ado, Megan, I'll let you take it from here.
All right. Thank you so much, Jamie. So just before I introduce our wonderful speaker, I just want to talk briefly about Dr. Shar. So we make Shar gluten-free food. We are an Italian company that's been doing gluten-free food for almost 40 years. So we're kind of, we've been doing this for a long time. And, you know, some of the more interesting and relevant things to this community specifically is that a lot of our foods have been recently certified as low FODMAP by Monash University. So something that a lot of people don't know and maybe would be helpful to their patients. You can find out all the information about that on shar.com. We have all of the products very clearly listed. And then just another thing that might be interesting to you, you know, this community of healthcare providers is so important to us. And, you know, we also, you know, want to support you in any way that we can. So we have a variety of resources, webinars, educational resources, research. We really try to support you in everything gluten-free related and now in IBS. And so we've been working with Anne on a lot of these projects for years, and we're so excited to kind of expand our ever-growing healthcare provider community, especially the dietitians. I'm a dietitian, so I love supporting with nutrition content. And with that, I'm going to introduce Anne. So again, Anne needs no introduction, but Dr. Anne Lee is a registered dietitian with over 20 years of experience in celiac disease research, education, and clinical work. She currently is a practicing dietitian and assistant professor in nutritional medicine at the Celiac Disease Center at Columbia University Medical Center in New York City. So another New Yorker. She's actively involved in research, and you'll find her name really on so many important celiac disease publications. The focus of her work lies in the impact of the gluten-free diet, dietary compliance, and the association of social anxiety and eating behaviors and disordered eating patterns in the celiac population. So with all of that experience, she's truly an expert on the topic at hand today, and I'm so excited to turn it over to Anne.
Thank you all very, very much. I'm going to pull up my screen and we can get started. I'm going to share. Okay, just give me a minute. Sorry, I thought I had it up and okay. Okie dokie. And let me just move this out of the way. Here we go. Yep, just unfortunately the little thing on top is covering my start the slideshow. So
and you can click in the bottom right of your screen. There's that little slider bar, but the one next to it, just up a little.
Oh, yep, got it.
There you go. Perfect.
We're okay. We're on. So
beautiful.
There's one thing to be said for technology and another thing for patient care. And I guess the two just don't always match. But anyway, I am more than happy to be here tonight. It's my pleasure to be associated both with Epicure and with Shar and to participate in the great work that they do. Tonight, we're going to be talking about whether it's non-celiac gluten sensitivity or IBS, and I wanted to just share some of our aims that we will, at the end of this, really be able to identify the difference in the diagnostic pathway between the two, look at the different diagnostic criteria, and then really describe the differences in the treatment of the two. And it's really a gluten-free diet versus a low FODMAP and why that's important, and the little nuances with that. So we're going to look at IBS first and kind of go through treatment and diagnostic criteria, symptoms, then look at non-celiac gluten sensitivity, and then really finish with looking at some of the research identifying both the reasons why we need to be able to differentiate between the two and the importance in our nutritional care of our patients. So we're going to begin with what is the concern behind the labels and why is it important for us to know the differences between IBS and non-celiac gluten sensitivity. And it's really important because with both of them, there's not a specific diagnostic biomarker that has been identified. And so in both cases, there are criteria in which to help diagnose these patients, but it's not a perfect criteria. And so it's really left with, trying to decide, trying to help your patient navigate through and come to a diagnosis. The reason this gets very murky is that the presentations are often very overlapping. And which brings us to the question is, why is it important to really differentiate between the two? And the reason is that we need to tailor that treatment and clinical follow-up to the specific symptoms and to the diagnosis, whether it's IBS or gluten sensitivity. And also to not minimize the importance of having a diagnosis for these patients to say, this is what's wrong with me, and to really have a name with which to define their symptoms so that they know it is not in their head, as many of them have been told multiple times by their clinicians. So when we start looking at IBS, we want to start with the prevalence. And it's important to know that although, when we see services like Epicure and, the products that are now labeled from SHAR for being low FODMAP friendly, that although it seems like there's much more awareness, it's really small compared to the prevalence in the population. We feel that it's about 10 to 15% of the adult population globally, which represents about 45 million people here in the US alone that have IBS. But what's a key factor here is that of that potential 45 million that we know, there are at least 5 to 7% more that are undiagnosed, that represents only a 7% of the potential that are diagnosed. A new development that we're beginning to see in our pediatric population and our GI clinics is that we're beginning to see that we're finding IBS diagnosed in children. It tends to be in that preteen teenage area and up through early adulthood. But we are starting to see very clear definition of IBS in the pediatric population. Whether it's in the pediatric population or the adult population, we find it's predominantly female. It's about two in three are female. And that's important because when we often think of that diagnostic process, we need to really pay attention to what our patients are telling us in terms of symptoms and realize it is 2 in 3 with our female, but we do have a significant portion of males who are presenting with IBS symptoms. Important is that I think in that early data on the prevalence is that we're seeing more men describe the symptoms now than they had in years past. And about that diagnostic process, IBS is a chronic, relapsing disorder that can be lifelong, and we need to understand that we need to help our patients understand the symptoms, get the diagnosis, so they can manage and maneuver through life. The Rome 4 diagnostic criteria for IBS includes a recurrent abdominal pain on average of about 1 day per week in the last 3 months. But it also needs to be associated with one of the following 3 items. That it's related to defecation, it's associated with a change in frequency or consistency of the bowel movement, and that symptoms have been persistent for at least 6 months. Now, that's important because when all of us, and I think of the time we're living in right now, increased anxiety, increased stress that can be temporary, can give us IBS-like symptoms. But a true IBS diagnosis is something that's persisting for more than 6 months. And that's important to differentiate between the person that's kind of maneuvering through life and life stressors versus something that is a persistent, ongoing, abdominal pain with recurrent symptoms. The prevalence of it globally, as you can see, it's over 20% in North America, some areas in Europe, and some areas in Latin America. But important is that we can see that it's definitely related to a certain amount of the more urban lifestyle, the more industrial nations, and associated with stress and anxiety to a degree. When we look at the classification, once we get that diagnosis, IBS is then classified into 4 different categories. It's with predominant constipation, diarrhea, mixed bowel habits, or an unclassified grouping. What's important, the reason it's important to differentiate between the two is because that will vary the treatment, and it changes the focus of the intervention. With the constipation persistent, it's more than 25% of the bowel movements are on that Bristol stool chart is a 1 or a 2. With the predominant diarrhea classification, over 25% or a quarter of the bowel movements are really the type 6 or 7 on that Bristol stool chart. I'm sure everyone is familiar with the Bristol stool chart. It's something you can find online. Interestingly, I would say if you don't use a copy in clinical practice already, I would download one and print one out. I can't tell you how many times I've taken out my little Bristol stool chart and looked at it with patients. And that's been an easy way for them to start the discussion on bowel movements and bowel habits, but also for them to see the difference between the different types of bowel movements. And sometimes that helps them classify how many are in which category. IBS mixed habits is one that is a combination of the two. For those that are in that unclassified category, they don't meet the 0.25% of the bowel movements in either 1 or 2, either the constipation or the diarrhea, but they do have that persistent bowel changes. There's a change in consistency, frequency. It may just not be consistently diarrhea or constipation, and it has lasted for more than the 6 months. In terms of treatment options, we're going to look at this in 2 different categories. We're going to look at the non-dietary treatments of IBS and then the dietary treatments of IBS. In terms of pharmacotherapy, there's, this is why it's important to differentiate between the categorization of the IBS, because if it's diarrhea predominant, you treat it with antispasmodics, with bile salts, with antibiotics, or with antidiarrheals. If it's constipation dominant, the laxatives or the lubricants. Also looking at targeting pain and to look at the source of that pain in addition to being the gut source, whether it's an antidepressant or a serotonin inhibitor. But also besides the pharmacotherapy and the dietary therapy, there's been really an emerging area of looking at those other aspects of treatment, whether it's lifestyle changes, different supplements that can be used, psychological therapies, or even biofeedback. And I think that while we sometimes think these are out of scope of practice, I think it's very important for us to be aware of this and to help refer or direct our patients, because they may need more than the standard pharmacy therapy or dietary therapy. And what we're realizing, and we'll talk about a little bit more, is some of that adjunctive therapy. In terms of dietary therapy, we really want to look at dietary therapy in 3 tiers. One, for some patients, it's really looking at their dietary patterns. What is their usual meal pattern? And how does that compare to that healthy eating Mediterranean type of meal pattern? Do they need to look at the percentage of caffeine, fat, alcohol, or spicy foods that are in their diet on a daily basis? Is it that they're eating all of their food late in the day? They're not eating during the day. Are they, looking at ordering in all their foods versus cooking some? Is it a lot of processed foods versus also, whole foods or home prepared foods. And that would just be really under that kind of healthy eating modifications, that when we look at their eating patterns, we need to look at it in terms of the balance, in terms of not just meal pattern, but the types of foods, the processing of foods, and the use of whole foods. The second area we need to look at is the exclusion diets, and that's where the low FODMAP diet comes in. We can also look at it in terms of, we've had several patients recently that have been, they're not cooks, and where they're used to eating out all the time and they're now home, are eating far more processed, canned, and packaged things and minimal amount of any whole or fresh foods. So we need to look at that. And also the gluten-free diet is another aspect of this, where they may not need a full low FODMAP diet, but just a gluten restriction. The other thing to always keep in mind is the fiber modification. And that would be depending again upon that categorization of the type of IBS, whether it's constipation or diarrhea predominant. In terms of the implementation, and this is where Epicure has done an amazing job in making life easy in this, but we really want to make sure that as we walk our patients through the process and implementation of a low FODMAP diet, we really want to make sure that we understand the different stages and our patients understand the stages. But most importantly, not just understanding the nuts and bolts of each stage, but understanding the need for patience and time with implementing each stage. The first stage of the basic procedure is to, you assess the patient's needs. Phase one is that restriction, that, restrictive phase, where we take out all those high FODMAP foods and replace them with just low FODMAP foods. With that, we look at that for a 4 to 6 week time period before we start the re-challenge phase. The phase two of the re-challenge phase is that very slow and systematic reintroduction of foods to really identify the specific triggers, because we don't need to restrict foods that are not triggers. We really want to be very careful and systematic in doing that re-challenge so we can identify those foods and eliminate only the triggers that need to be eliminated. The third phase is the personalization, where we really work with the individual to get that diet to be as flexible as they are, for them to be able to adapt it to their daily life and really customize it to their needs. Is it someone who travels not recently, but usually travels for work a lot? What are their hours? Can they bring a lunch? Do they have to eat at work? Those kind of things all need to be included in that personalization phase. The basic phase one, the restrictive one, is we take out, as we said, all those high FODMAP foods, and it would be done by the different categories of fermentable carbohydrates, and then really emphasize a balanced intake of all those low FODMAP foods. Again, really making sure that the patient has variety, that they're satisfied with the variety of foods that they have, and that they're getting the nutrition that they need as well. The restrictive diet can last for 2 to 6 weeks. What we're looking for is improvement in symptoms. If we get no improvement after 6 weeks, we stop and we start the re-challenge, okay? Because if they're not improving, it makes no sense to restrict them further. This is one area that I'm sure you've all seen, where we've had several patients that have been on this restrictive phase of a low FODMAP diet for months and months and months, and they get stuck. And that's really important that we move our patients beyond that for both physical reasons, to ensure that they're getting full nutrient need, they're meeting their full nutrient needs, but also emotionally and psychologically, we don't want them to restrict more than they need to, or to get stuck in that restrictive mindset. The simplified food groups from that are the fructans, fructose, lactose, mannitose, sorbitol, and GOS. And you can see that, for some of our patients, when we're in that restrictive phase, we may need to break it down so it's very simple and easy for them to understand. I've actually talked to some patients about the low FODMAP, and they look at you like a deer in headlights. And sometimes you need to step back and say, nope, we can do this. This is how we're going to, give you a simplified list. Let's take these out. see how they do for a week or so, and then you can move on to that more elaborate list of the high and low FODMAP foods. But sometimes even just doing a very simplified approach of like take out these main high FODMAP foods within each group has yielded a reduction of symptoms. So that reintroduction pathway, this is the phase 2 part of the low FODMAP diet is something that we really need to spend our time with. We need to guide our patients to work with a trained dietitian. We need to make sure that they're really challenging each group separately, that they're challenging the foods in appropriate portion sizes, and to add the foods back into the diet if they're tolerated, and then to finally get to stage 3 in that personalized diet. So that reintroduction, again, can't emphasize it enough. It's one group at a time. It's one single FODMAP food, and it's a quarter portion to start. And I've had some people do where they said, oh, I added honey, but I added honey to everything I ate that day. Well, they will have reactions, so that we really need to make sure that when we're doing that reintroduction phase, that we really do educate our patients in terms of it's that single food, and to monitor the portion size, and to really make sure that they're not advancing the portion size or the number of foods too quickly. And again, that importance of serving size. It's really, when we look at an avocado, which is, the latest go-to food right now, that the low FODMAP serving is only an eighth. But how many people do we know, or many of our patients, they eat an entire avocado at a meal? And so really we need to guide them to the proper portion sizes. And it's important to highlight this because I think not only do we need to look at the type of FODMAP consumed, but the amount. And I know that, think back to, when we were all doing our internships and such, and you were doing your 24-hour recalls and your patient said, I had a bagel. But think of the difference between a New York City bagel and a bagel you find in the frozen food section out in California. And we really need to make sure that we query, the size, the portions, the type, because these are things that will make a difference in terms of producing symptoms, even frequency. Are they eating a bagel every single day? And is it that big New York City bagel, or are they eating it on Sundays? So that those are those are things that we really need to look at, but also to keep in mind, what are they combining with? Are they having that bagel with the entire avocado? That may do many of our patients in. So we need to educate on all these little nuances of the diet. That reintroduction pathway too, as we said, it's, each step is very important. And that phase 3 is that personalization. And that's just so important. We really need to, look at the foods that weren't challenged as they go forward. Do we want to re-challenge them? Do we challenge them in combinations? Really to personalize for that patient. You may have a patient that reacts to fructans, and so beans are a question, but they're somebody that loved their beans. Well, maybe we need to relook at that and say, well, if we did a quarter portion and had that quarter portion of those beans that you love and are part of your cultural diet, but we had them with other very, very low FODMAP foods, does that combination work? And to, again, discuss it with them and talk about re-challenging within that new combination and see if that does help. The other thing we need to be aware of is there are some foods that, Monash and other companies have not identified all the FODMAP content. And so using a symptom tracker is something I found to be very, very helpful, especially during the reintroduction phase and the early part of the personalization phase, because that will help us identify patterns, combinations, things that will help them identify triggers, which now will liberate them because we can eliminate those symptoms. The other thing to really think about, and I know this is a busy slide, but it kind of looks at each of those three phases. But the other thing I want to say is that we also need to look at this list and say, okay, we know many of our patients are not going to be able to make it through this this pathway. And we need to really make sure that we monitor how they're adapting, and really to think about, do we need to bring in some of that adjunctive therapy, or do we need to simplify things for them? When we think of doing the implementation, there are special considerations. We need to think of our patients that are following a vegan or vegetarian diet, our diabetic patients, or patients with histories of disordered eating or eating disorders. These are not people that we want to make sure these are not patients that we want to put into a more restrictive dietary habit. We really want to personalize that and really talk to them about what is the best approach for them. And there's ways to make it happen. When we think of our vegetarian patients, we really can teach them that, soaking the beans, using alternatives can be ways that they can maintain a vegetarian diet, but still also go through the low FODMAP regime. And with their eating disordered patients, we use that very simplified approach and monitor very carefully that they're not over restricting the categories. So that, again, the use of that simplified restrictive phase is only remove the foods that are very high in FODMAPs, looking at those simplified groups, and leave in foods that are tolerated. Really have that very in-depth discussion early on in terms of what they feel are foods they tolerate. These are the patients that carefully, that symptom log may be something, the symptom tracker may be something to use so that they can help identify foods that, if they know every time they drink milk or have cheese that they react, then we don't need to restrict it. We can use a simplified approach to eliminate that burden for them. And that kind of brings us to non-celiac gluten sensitivity, because when we think of that burden and that trial of the diet, it's a long process with IBS and with FODMAP, and the contrast is important. With non-celiac gluten sensitivity, again, there's no biomarker. It's a series of looking at symptoms and really identifying foods with the patient that may be problematic. It's with non-celiac gluten sensitivity, it is an inflammatory response, it is an immune response, but it's different. It's an innate immune response compared to an autoimmune response with celiac disease. And like celiac disease, non-celiac gluten sensitivity can have both intestinal and extraintestinal manifestations. And again, many of the symptoms overlap with IBS and celiac disease. Some of the common symptoms with non-celiac gluten sensitivity are things that you'll see in IBS: the bloating, abdominal pain, diarrhea, nausea. They can have heartburn, but they can also have fatigue and headaches and migraines. There can be anxiety and behavioral changes, depression, joint and muscle pain. So that you can see many of these symptoms cross over into many other GI issues. And this is why it's so important to be able to differentiate and identify. With gluten sensitivity, the diagnostic criteria is the Salerno criteria. And the Salerno diagnostic protocol really is an involved protocol, making sure that we really use a double-blind placebo-controlled approach, so that what happens is there's really a two-step process where, after making sure that you have ruled out wheat allergy and celiac disease, and we'll look at a pathway in just a minute to help further explain this, we make sure that the patients are on a gluten-containing diet for at least 6 weeks. Okay. At that point, they come into the clinician. We have a baseline visit. We have them fill out the gastrointestinal symptom rating scale. It gets rated. And at that time, after being on a good gluten-containing diet for 6 weeks, we look at their symptoms and we look at the amount of gluten they have. At that point, we then start a gluten-free diet. And we ask them to start, to persist on the gluten-free diet for an additional 6 weeks. At that point, we again have them rate their varied symptoms, and a decrease of at least 30% of those symptoms is considered a positive response to that gluten-free diet. After the 6 weeks, We have them come back to clinic and we do a gluten challenge because we feel that, eliminating gluten will give you that symptom release, but we really want to make sure that we challenge it to make sure that we're getting enough of symptom reduction, but we do it in a placebo crossover way so that the reintroduction of gluten is double-blinded, placebo-controlled. It's a crossover design, so the same patient is given both gluten-containing products and non-gluten containing products, and we monitor those symptoms. Because as you look at the step, they went through eating gluten to then not having gluten and measuring those symptoms. And that way, within the same individual, we can look at the different symptoms in both gluten challenge and not. And with that, when we look at this diagnostic procedure, we can really say that 6 weeks on gluten, 6 weeks off, and then 6 weeks of a challenge. And many of our patients may not make it through that, and we realize that. So what ends up happening is with gluten sensitivity, it often is a diagnosis by default rather than going through the strict Salerno criteria. The best way to diagnose is going through that, but we're finding that not all of our patients can make it through that. So what we find is that it looks, and again, sorry for the busy slide, but it looks like this. When we suspect a gluten reaction, we have to suspect celiac disease as a primary or wheat allergy, and we have to test for both to rule them both out. With celiac disease, we would do the antibodies. If the antibodies are positive, they would go down to a duodenal biopsy, and if the biopsy is positive, we have a confirmation of celiac disease. If the biopsy is negative, potentially that could be gluten sensitivity. With wheat allergy, we would do the skin prick or the IgE serum antibody testing. If that is negative, it is not a wheat allergy. If it is positive, it is a wheat allergy and therefore not gluten sensitivity. If the IgA is negative and we do a biopsy and the biopsy is normal, again, it would be potentially gluten sensitivity. The reason there are the two pathways is that we have some patients that when the antibody levels, celiac antibody levels are drawn, they can be borderline or negative, depending if they're IgA deficient. And therefore they could have a positive biopsy with negative celiac antibody levels. And so it's important to look at all aspects of this algorithm to make sure that we're not missing any of our patients, okay, and where they fall into this category. In terms of prevalence, it's actually, the range is huge. We've seen reports everywhere from between 1 and 13% of the population. A recent study here in the United States identified 6% of the population may be suffering from gluten sensitivity. A report with Dr. Sanders out of the UK listed it as 13%. But again, because of the low diagnostic rate, we feel that probably is much, much higher. The other problem with this is when you look at that it's most commonly a diagnosis by default rather than than patients really going through the entire Salerno diagnostic criteria. We feel that there are a lot of patients that just give up along the diagnostic pathway and follow the gluten-free diet. And we really want to try to encourage clinicians to be more mindful of it and help their patients be diagnosed rather than just by default following a diet they don't need to. Okay. The one area that's very fascinating with gluten sensitivity is there are some interesting emerging connections. There's not a lot of good long-term research done in this area yet, but there are potentially links with autism, with schizophrenia, and they think it links back to that blood-brain and brain-gut, blood-brain barrier and the brain-gut connection. And in terms of that, some of these larger protein particles of gluten do cross through the intestinal mucosa and then do get into the bloodstream and may be causing irritation in the brain. The studies have been limited There've been small populations, especially in autism, the clinicians rating the change in the children's behavior. It's not all uniform across the different studies, so it's hard to really form a good consensus. But these are areas that we need to be aware of and to look to for further stronger research in the future. With gluten sensitivity, the treatment is a gluten-free diet. What's great is there is a plethora of choices of foods that are naturally gluten-free, and we encourage our patients to really partake of those. Gluten is in, your different grains, wheat, rye, and barley. There are derivatives, prepared items, beverages. It's really, as much as we love to say that there's tons of gluten-free food, there's also many, many foods that gluten is added into. Simple things like soy sauce and Twizzlers and things where you wouldn't expect wheat flour to be added, and it is. So we need to help our patients navigate through so they understand the little nuances of where gluten can be hidden. In terms of overall treatment, it is elimination of gluten, emphasis on the naturally gluten-free foods. Oats are always questionable due to cross-reactivity, and we want to always be mindful of that chance gluten exposure. We're seeing in some research that's coming out now that there's some thought that the patients with gluten sensitivity may actually be more reactive to chance gluten exposure. Their reaction may be rapid compared to the individual with celiac disease, and it even may be more intense. We're finding that some of this intense rapid reaction may be more neurological based than GI based. But again, emerging areas and areas that we need, further and deeper research to really help identify these reactions and to help differentiate between them. One thing that's important is for, when we think of a gluten-free diet, and this is where, again, I emphasize that importance in trying to get our patients to go through the diagnostic process, is because although there can be a wealth of gluten-free food that's delicious and healthy and satisfying, there can also be many nutritional deficiencies associated with the gluten-free diet. If patients aren't careful about making sure they get a good balance of foods, they get, the different grains in, we can see vitamin and mineral deficiencies. Specifically, with the B complex vitamins, if they tend to eliminate grains, we worry about calcium with their bone loss, if they're eliminating lactose. So there are many, many things that we really want to make sure our patients are properly diagnosed if we can, and that they're really well informed on making sure they're making good nutritional choices, whether they're on low FODMAP or a gluten-free diet. And one question I always get from some of our practitioners is, why can't we just tell our patients to Google the diet? Do they need to spend that much time with you? And I keep telling them, yes, they need to spend more time with me and all of you, because on the internet or when they Google it, how much misinformation is out there. There is some good information, but I am sure you all have horror stories of patients that come in and say, well, I read, and it's something that is totally erroneous or conflicting, and they get very confused as to what to follow and what not to follow. There are so many conflicting low FODMAP lists that I've had patients come in with 4 or 5 different lists saying, I don't know what to do. And we need to really help them navigate through. So we can't just tell them to Google it. We really want them to come and see someone who's trained. But more important than that, dietary treatment and intervention, when we think of both of these syndromes, these conditions, food is more, dietary treatment is more than just the food that they eat. When we think of, especially at this time in the holidays, we know food is woven into really the culture of our lives. And when we think of now making a major shift in what you're eating on a day-to-day basis, it's going to affect every aspect of your life. And when we think of that, we need to be cognizant of then that variety or that, extent of the burden of these diagnoses on our individual patient. When we look to their social and professional life. How hard is it to say that, well, I can't have that, I can't have lunch with you? The fear we have seen in many of us studies in IBS and the gluten-free diet, the fear of traveling and social events, the increased number of our patients that have, work-related issues and sick days with IBS. So there's so many things that really create a huge burden on our patient. So when we think of treatment, it's not a simple diet, it's multifaceted. When we look at the perceived treatment burden, IBS is very high. It's right behind celiac disease, excuse me. And we need to realize that for a condition that's not well diagnosed, not well recognized, probably well underdiagnosed, the burden is enormous. And we need to be responsive to that in our patients. When we look at quality of life in IBS, there's been several studies that have been done that show that, symptoms directly impact daily work performance. With the one study done by Progetto, that we found the number of sick days or the number of times people changed jobs because of the inability to maintain their work performance was huge. And that will have a lasting impact on someone's professional life. What was interesting in the study he did too is that there was a significant association between symptoms and an individual's social life. The people that had more symptoms more likely lived alone by choice. And they would say that well, no, I live by myself. I don't want to share an apartment because it's too embarrassing to have to be running to the bathroom or share a bathroom with a roommate or something. The symptom burden was also, reported in the Tornblom study, where they found that 33% of the participants found that the 33% of the participants reported they felt their healthcare professional didn't understand them, didn't really get what they were going through on a day-to-day basis. They didn't understand the impact of symptoms on their daily life. And they found that the symptoms that were most troublesome was the chronic fatigue and the urgency to use bathroom facilities, and that was something that was totally misunderstood by the healthcare professional and not understood in terms of how that impacts one's daily life. And just, the study by Dong just again reiterating the huge impact on overall quality of life. And when we think of these symptoms and that impact on quality of life, we have to realize that has a rippling effect, not only through the individual's various aspects of life, but through everyone that they come in contact with. That if they're not the person that's living by themselves, but in a family situation, that's going to impact all members of that individual's community and family. And we really need to start looking at what is that overall effect. We did a study where we looked at the impact of celiac disease diagnosis on a child and what that then ripples out into the family. And what we found is that it had significant impact on not just the mother and the father, but the grandparents, the siblings, and that extended family. Each person had a different role, and that role was affected very differently, but that effect went through the entire individual's community. And I think that while we identified this in celiac disease, I think the same thing can be applied to both the individual with IBS and gluten sensitivity, because that not only the symptoms, but the need to follow this restrictive diet is going to ripple through the individual's extended family members. So what do we know and what can we do? We know the quality of life in individuals with IBS and celiac disease and gluten sensitivity are much lower than the general population. We know that the social domain, work, social, travel is very affected. But what can we do? Do the scores change if you have a better social support network versus, someone who doesn't have a social support network? Does the type of social support network make a difference? So we looked at these things and found that in a cross-sectional study we did, again, in individuals with celiac disease, but again, based on symptoms, based on the restrictive diet, these would be applicable to our patients with IBS and gluten sensitivity. That we found that, overall quality of life scores are not bad compared to the general population, but are much lower. Overall, the scores are not bad compared to previous studies, but they're lower than the general population. And we also found that it was different depending on the type of social network that people relied on, whether it was a face-to-face community versus an online community. We found that the people that only relied on an online support community had a significantly lower quality of life score than those individuals that relied predominantly on a face-to-face type of support system. Church group, support group, meetup group, but something where they're in contact on a daily basis. That seemed to make a big difference. The people that used both, did better than the people that only did online, but not nearly enough to reach the difference for the patients that did just face-to-face. So the impact of diet on quality of life, when we look at social situations, and we've looked at our different studies, we've found that the social life of an individual is most largely impacted by their dietary restrictions, that the burden of the disease affects quality of life, health perception, but the diet itself has a very distinct impact on one's social life. People have, from both our IBS, our gluten sensitive, and our celiac disease patients, our patients have told us they hate being the center of attention. They hate being the one to ask 1,000 questions of the waiter. They don't like to, be the person that's different when someone, they order in a birthday lunch and they have to be the person saying, no, not me, or I can't. And that they can't be spontaneous. And especially with our teenagers, that was something that they really said, that they felt they just couldn't get up and go with their friends. And so we can see that the diet really has a significant impact on that. From that, we said, well, how much does the restrictive nature of the diet impact this social aspect of one's life? And so again, another cross-sectional study, we did it with adults and teens. We did a vigilance scale based on the 24-hour recalls that we did with them, and the knowledge on reading a food label and being able to identify both FODMAPs and gluten. And we had some open-ended questions. And what we found is that overall, the adults that were extremely vigilant, so really had very high knowledge scores and had very high scores on questioning waiters and being very vigilant with their diet, not eating something that wasn't labeled low FODMAP or gluten-free or certified, that they had a statistically significant decreased quality of life score. And when we look at that difference, a 10-point difference in scale is a major shift, and one that is concerning. Interestingly, while our adults that were highly vigilant had a lower quality of life score, the teenagers didn't. Now, but what was interesting with that is that then when we looked at the teens and we looked at their open-ended responses and some of their other comments, we found that while they didn't have a change in quality of life, they had a huge change in their social behavior. And that was answered in those open-ended questions. And that's where they were saying eating out was horribly frustrating. They would not go out with their friends or would meet them after they ate, that they really had a mistrust of waitstaff and of labels. And they found that it was really hard to manage that gluten-free diet. And it was 70% of those teens compared to only 56% of the adults that really felt that the diet had that huge of an impact. And this led us to look more closely at the teens. And I know, Jamie, let me know if I'm too close on time. That we looked a little bit more closely on our teens and really wanted to see what their behaviors were around that diet. And so what we found is that over 50% of them actually had eating behaviors that would be considered maladaptive. so that this were things that where they would choose not to eat, they would avoid eating situations. And it's concerning because I'm going to go through this quickly so we can get there, that the maladaptive behaviors included, they were very, emotion focused, they were very nervous, they were very anxious. They spent a lot of time focusing on labels and on food and checking and really being overly concerned, spending more time about food and labels than they did on other aspects of their social life. And this is concerning for us because when we look at these traits of maladaptive eating patterns, we find that these are traits that are associated with eating disorders. And so we really are concerned about these restrictive diets and the potential to tip someone over into that eating disorder category. And so it raises the question of how best can we empower our patients? What services do we need? Services do our patient needs? What supports do our patients need? How can we make those connections? And it made me realize that we really need to go back to that treatment slide for IBS again, and really look at those alternative therapies and start thinking about how to include them into our wheelhouse. When we look at those psychological therapies, we look at their, symptom logs and things, the responses to daily stress, to daily triggers, the, different things that we can encourage our patients to do is to be aware of those triggers, to look at their daily stress and anxiety levels, to think about ways that they can incorporate de-stressing activities, yoga, meditation, the nature immersion. It's sometimes called forest bathing, if you will, where they really looked at people who did something as simple as taking a walk in a park compared to walking down the city block, and measured the difference in stress and anxiety levels and blood pressure compared to, before the walk and after the walk. And it was statistically significantly lower. If we took that same person, had them go out and take a walk in the woods, again, was even further reduced. But things that we need to just think about, ways to coach our patients that they can incorporate into their daily lives, things that will help them manage their stress. So if we look at that view from 30,000 feet, we need to emphasize that the importance of a balanced intake. We want our patients to eat well, to eat healthy, to enjoy their food, and to really get satisfaction from not just the food, but from the sharing of the event and the meal. But it's more than food, as we said. We want them to be active. We want them to make sure they're having enough fluid, and they are including rest and relaxation. These are part of our daily life and needs to be included. So we need to look at all these different things and just realize it's not diet alone. We need to connect our patients and support. We need to get them to de-stress, and we need them to eat well and happily. So, and with that, I thank you. And I'll stop share.
Yeah, great. Thank you so much, Anne. We do have some questions if you
Sure.
don't mind sticking around for a few
No,
extra.
I'm sorry. I just realized we went a little bit longer. I got carried away.
No, it was great. So the first question is, if there is no improvement following the low FODMAP diet in 2 or 3 weeks, do we need to continue for 6 weeks or stop? If improvement is seen in 2 to 3 weeks, can the food challenge start before the 6 weeks?
Yes, great question. That if we see no improvement in 2 to 3 weeks, I would say continue for a little bit longer and see if, and really go through that list of foods that they're eating, and just to help identify, is there, an imbalance in fiber from day to day? Are there other things that are affecting that? If we see improvement in 2 weeks, yes, you can go into the re-challenge phase. Absolutely. If you're not seeing the improvement, that's where you may need to stretch it and really dive into that food diary to see what's going on. But if you're already seeing improvement, yes, don't keep them restricted longer than you have to.
Okay, and a similar follow-up question to that, if a patient does not show any improvement with the elimination, why start challenges, or would you start challenges?
You can start challenges because we want to see if we have eliminated everything and they're not improving. There's 2 schools of thought. One school of thought is, no, you're done, because if you've taken everything out, there's no need to go through the lengthy challenge phase because you're not going to identify anything further. And that's where we may need to do some additional testing. Is there anything else potentially going on? And also to go back and look at what was the pathway that they got there? Did they go through and really identify if they have celiac, to weed out? Did they eliminate the potential to be celiac or Crohn's, colitis? Did we go through and do a really good diagnostic workup up to that point? That could those symptoms be coming from something else?
Okay. Okay, so the next one is, how long would you expect it to take for symptoms to arise after the step 2 gluten challenge for a non-celiac gluten sensitivity diagnosis?
I'm sorry, can you do that?
Yeah. How long would you expect it to take for symptoms to arise after the step 2 gluten challenge for non-celiac gluten sensitivity diagnosis?
Actually, great questions. We would expect it to be rather quickly. We don't expect it to be a full 6 weeks. We really would, if they were following the Salerno criteria and they did that gluten challenge, we would expect to see symptoms quickly. I mean, some of our patients, it's that first day, that first meal, they're telling you, no, I don't need to do this for 6 weeks, but the criteria is to do a 6-week challenge.
Okay. This one's kind of related. So can you speak to what research has been shown regarding the difference, if any, between non-celiac gluten sensitivity and non-celiac wheat sensitivity, with the potential of fructans as the trigger as opposed to gluten?
Great question. Great question, because we're actually want to investigate that, because even within not just gluten sensitivity, but even within our celiac patients, we have some patients that start a gluten-free diet and don't get relief. And we've actually wondered if it's some component of the wheat. Is it fructans? So the research isn't there yet, but it's in development, because we question that if our patients are diligent on their diet, why are they not, now symptom free? And we have to be, what we've realized is that we've gone through and wanted to make sure that, one, they have adequate fiber so that the system is working, two, that they are indeed following clearly a gluten-free or wheat-free diet so that there's no cross-contamination. And if they're still, having symptoms, we know there's something else going on there. But we haven't identified it yet. There is a strong feeling that fructans may be an additional trigger, even in celiac disease, believe it or not.
Yeah, interesting. Looking forward to that research. Okay, let's see here. Do you have any experience or comments with exocrine pancreatic insufficiency in IBS?
I'm going to be very honest and say no, not enough to give you a good response. However, where I would direct you is to the University of Monash, to their website. They have extensive information and education materials, and it's fabulous. I would encourage you to look there.
Awesome. Okay, I just have a couple more. I'm going to group some of them a little bit together, but what are your thoughts on IgG food sensitivity tests for assessing gluten sensitivity?
The IgG tests are used in conjunction with the IgA testing. They were the initial testing used years ago. Now we tend to do a combination of the IgA tissue transglutaminase and the deaminated IgA and IgG. The reason for the IgG testing in combination with the IgA testing is if a person is IgA deficient, their IgA antibodies will not show up, and that's where an elevated IgG might. But the IgG is not as strong of an indicator as the IgA antibodies. We tend to do the panel and also the total IgA so we can identify if someone is IgA deficient.
Okay, awesome. All right, so these are kind of similar. So someone's asking about someone's saying they didn't realize gluten was in cooking spray. Is there a comprehensive list of where patients can locate gluten? And then another person asked, is there a definitive source of FODMAP lists? So
okay.
directions for those two.
For both of them. For The FODMAP I would really recommend. Again, I am a fan of the University of Monash as the best source. And the reason for this, it's not just a personal bias. They have actually been the center who has done the testing on identifying the actual specific FODMAPs in different foods. So I really feel most confident in their list to identify foods that are high in fructans, lactose, fructose. For gluten-free, there are several sites. There's the Columbia site, University of Michigan is excellent. SHAR has wonderful educational materials. What I would direct is Monash for low FODMAP for sure, or a reputable source like Mayo Clinic, University of Michigan, and it would be the same idea for gluten-free.
Yeah, great.
Just know your sources. That's the key.
Absolutely. And yeah, I know, and we could probably share some of our resources after this with the attendees, but you know, I know you've worked on a lot of those and I've worked on them, so they're pretty comprehensive, but okay, just two more.
Yes.
What connection, if any, does FPIES have to gluten and IBS?
I don't know that they've been well identified as yet. You know, Megan, have you heard anything on this either? I know people have talked about it, but I don't think anything has really, again, there's so much that's just not researched yet, you know, and I'm not sure that it's been connected.
Yeah, I haven't seen anything on it either. FPIES is truthfully not something I've worked with a lot, but from what I've seen, I haven't seen anything linking them, so I'm not totally sure.
I think it gets muddied again because symptoms tend to overlap. And when we're looking at food sensitivities and reactions, things kind of do get clouded, but there hasn't been good definitive research linking the two at all.
Mm-hmm. Yeah. Okay. And then last one,
I guess, yeah, just one thing, but that's not to say that an individual couldn't be reactive,
right?
That it's not well studied and researched.
Mm-hmm. Okay, and we have a clarification. So did you say that people with celiac disease may react to fructans for reasons other than FODMAPs? Can you just?
No, what we're finding is that, thank you for asking for clarification. That's good. We find that our patients with celiac disease who are on a gluten-free diet and they're maintaining a gluten-free diet, you know, they're taking out the wheat, rye, and barley, but they still have many foods that are high fructan in the diet, or at least we hope they do. They have their beans, they're good fibers and things. And we find that they can still be symptomatic. And we're beginning to think that there may be a sensitivity to the fructans. And it's not, you know, it's not that their celiac disease has changed. It may be that they have IBS in addition. There's no reason that they can't have both. But for patients that are not otherwise dual diagnosed with IBS, we find that they are more sensitive to some of the fructans. But really, this is early in this, and we're just beginning to draw up the project. We have some inklings, some clinical observations, but no strong research yet. More to come.
Your food partner in research, you know, two gals who are willing to help out, Anne.
That's actually where we're going.
I love that. We're engaged in a couple of studies so far and are proud to be a part of it. I don't know if you guys saw the question in the chat, but I think it's a good one. And I hear this sometimes from patients as well as practitioners who are asking about if a patient doesn't want to eat gluten for any period of time, really, because they know they feel bad when they eat it and have abdominal discomfort. What's your advice? Like, do they just not get diagnosed?
And that's where it becomes the diagnosis by default. And I apologize if it didn't make that clear. The Salerno criteria for gluten sensitivity, and even if they were, you know, the proper diagnosis for celiac disease is if you've already gone off gluten, we can't test your antibodies or do your biopsy unless we add gluten back in. But in all reality, the patient may not want to do that. And we have to abide by that patient's desires. I mean, if it makes you horribly sick, it's, you know, we can't do harm. So we would just accept that as not a possibility to challenge and abide by their wishes. But it's a diagnosis by default, unfortunately.
Megan, did you have anything else? Sorry to chime in there. I just don't want to miss.
Oh, I actually, no, it was, yeah, I think that's something that I see a lot of people that, you know, maybe connect with us through SHAR. A lot of times that's kind of the case. And I think, you know, always respecting the patient's wishes, and you said it perfectly, like, we're not allowed to do harm, right? So it's,
Right.
you don't want to make someone uncomfortable. And I think a lot of times patients are good at identifying their food triggers. So listening to your
Absolutely.
patients is really critical.
Very
We've
much
still
so.
strong. We've still got 161 people with us. Thank you, everyone, for and no surprise there, Anne. You always give such a compelling presentation. We've had a lot of people asking about whether the slides and recording and so forth are available. We will have the recording available, not the slides, though if you do have specific requests for content from Anne's slides, I'm happy to help see if we can turn that into something that, you know, we give credit to Anne, of course, but you guys can leverage in your practice. We do have lots of resources, download some flyers and patient educational materials, as well as nearly 20 other recorded webinars, all CPE certified, on our portal. So happy to support all of you however we can. Please provide feedback always. Megan, and your lovely humans, and your expertise and time and talent is so needed and appreciated in the world. So thank you. We owe you both a debt of gratitude, and hope you're having the loveliest of holidays.
Yes.
You deserve some TLC and R&R and all the things. So hope you're getting that for yourselves, as well as the rest of you in our community. Lots of
Thank you very much. Okay. Yeah.
Thanks, Jamie.
Have a wonderful.
Thank you so much. Yes.
Thank you. Bye, everyone.